السلام عليكم ورحمة الله تعالى وبركاته. أنا اسمي دكتورة منال ياسين، شغال هنا في اليو كي. I would like to share يعني my experience with you guys, and I hope إنها حتكون a useful experience. It's all based on observations plus my humble يعني observations plus observations from other ICU consultants plus trusted websites. And I managed to gather as much information as I can عشان أحط عليكم كلها في slides تكون useful for COVID management in Sudan. I'm sure إنه with all the يعني respect للسودانيز doctors هناك في السودان إنه عندهم the same kind of أكيد عندكم information كثيرة جدا and you've gathered a lot of information, but it's also nice to have the experience of others as well. When I think at some point إننا إحنا maybe في السودان we are a bit more lucky at this stage لأنه already the pandemic has started in other countries وفي حاجات كثيرة مثلا في management they had been revised it. في الأول management started people were quite overwhelmed and some things were done I wouldn't say in the wrong way but it wasn't the right approach initially. فحسا في حاجات كثيرة جدا revised وال hope إنه الإكسبيرينس دي تكون مفيدة لكم. الcohort of patients اللي كانوا عندنا we've had the ages were quite young ages 35 to 60 average. Most of them had diabetes and hypertension, but quite a lot of them were fit and well. High BMI was noted as well, and as I said, some of them had no past medical history. And it was noted that males are more affected than females. So the shortcut, COVID could affect anyone. The signs and symptoms, you would come across a patient that's saturating 50% on air. These are the calls that we get kind of from A&E, telling us that they've got this patient, they were saturating 50% on air, their respiration around about 30 per minute, they were started on 15 liters of oxygen, non-rebreather. This is the first line of management, and their SATs improved to 80%. When we go and see these patients, they are normal. Most of them are conscious, and they're talking in full sentences, despite the clinical picture that you see. Someone talking to you with the SATs of, full sentences with SATs of 80s. That's a bit kind of an odd presentation rather than the normal, typical presentation of people with sepsis. History of their history will have they will have high temperature, dry cough with or without sore throat, severe body aches and pains, shortness of breath or exertion, and most of them would have kind of self-isolated for 7 days or more. Diabetic patients, they may present with kind of a DKA picture. Diarrhea and vomiting have been noted as well, and most of these patients, because they've got they're running temperatures of 39 up to 40s, and they've been kind of hyperventilating, most of them coming in severely dehydrated. And you will, in the next few slides, you'll see how the initial kind of management that we used to do affected these patients, and most of them, we used to kind of give them furosemide and dry them quite a lot. And most of them ended up with AKI, as in acute kidney injury, and ended up needing hemofiltration. So beware that the patients are very dehydrated. They come in with or without an acute kidney injury. And we've also noticed when we've done the blood gases, most of them had normal lactates, which again does not fit the normal kind of a septic patient that you used to see in the past. Either that's noted on ABG or a venous blood gas. Regarding the blood biochemistry, classical, you find a very high CRP, lymphopenia, and it's associated with a poor outcome, high D-dimers, high ferritin levels, high fibrinogen, their liver function tests will be deranged, and high creatine kinase or CK has been noted as well, and this will reflect on the muscle involvement and severe muscle aches and pains experienced by these patients. And as I said previously, the lactates were mostly normal. Initial management, always remember at the back of the head that this is not sepsis or sepsis-related ARDS. So even the kind of picture of ARDS that we see in these patients is quite different from the typical ARDS that we used to see with sepsis. So give oxygen, lots of oxygen. Be quite generous with the oxygen, up to 15 liters on a non-rebreather. Non-invasive ventilation in the form of CPAP. We usually start with a CPAP of 10 and BiPAP. In not a lot of cases we use BiPAP, but we use it in our trust in patients who are slightly more tachypneic on the CPAP and then they need that kind of bit of support. So if CPAP, essentially, if you use CPAP with pressure support, that essentially is BiPAP. You can go up to a PEEP of 10 on the CPAP. Optiflow has been used in some hospitals. We didn't use it in our trust, but I think in Italy as well has been used a lot of Optiflow, which is the high nasal flow oxygen. And I think initially when the disease spread initially, the fear was to use CPAP or Optiflow because of they're all aerosolic and the virus lingers quite a good few hours in the room if you are using these aerosolic kind of procedures. But in view that you want to reduce the incidence of intubation or invasive ventilation, plus the fact that quite a lot of patients has responded or showed quite good response to non-invasive ventilation, then it's better that we use it and break the cycle and refrain a little bit from invasive ventilation. That let's not to say that invasive ventilation is not used. In fact, if patients, you watch them, if they kind of deteriorate, you obviously would intubate them early rather than late. But that's all down to the clinician and the person who's seeing them at the time. Voluntary proning on oxygen as well, either a non-rebreather or even on CPAP or Optiflow, it is very effective. So awake proning of patients has been implemented in almost all trusts. Even at home, if you are on high flow, or even at home when you're experiencing slight sort of breathlessness, you can actually prone yourself at home as well, and adopt the position of proning, as in hands over and just lie your face down at home, or as I said in hospitals as well, with using high flow oxygen or CPAP. Prone these patients, prone them early rather than late. It depends, you can prone them for 4 hours, as long as they can tolerate. These are on patients who are self-ventilating on oxygen, whether it's through CPAP or face mask. With intubation, we'll come and talk to that later. Always review the need, as I said, for invasive ventilation. Keep the patient well hydrated, because remember, these patients come in very high temperature, hyperventilating. They probably feel really bad and they haven't eaten or drank for good few days. So keep them, aim for euvolemia rather than flooding them with IV fluids. Most patients come to ICU after a few days of illness, temperatures 38, 40s, and they are hyperventilating and they are severely dehydrated. We've noticed high rates of AKI because initially we used to use quite a lot of furosemide, because when the disease came in, everyone was treating these patients as ARDS, where we used to dry these patients and keep them on a negative fluid balance, because of the pathophysiology of the ARDS that we used to see is that you get leaky capillaries and your lungs become flooded with fluid. And so to get the oxygenation better, you aim to dry them. But in these ARDS, the picture is completely different. So overuse of furosemide had led to unnecessary CVVH, which is hemofiltration. Hypoperfusion leads to poor pulmonary perfusion and increasing of the dead space. in these patients. Patients are hypercoagulable and high D-dimers and fibrinogen. So if you've got, and these patients, when they've done post-mortems, they found that these patients actually had quite a lot of incidence of PE in these patients. So again, it makes a lot of sense that you give a generous amount of fluids. Oliguria may have improved using lower PEEPs. These are all observations that we kind of seen in these patients. Again, improving the perfusions of the patients and making sure that they are not hypovolemic. Lung leak is not as prominent in this disease as classic ARDS. Avoiding hypovolemia, as this will impede the gas exchange and cause AKI. Progression to CVVH and hemofiltration increases the mortality. Avoid hypervolemia, so we aim for eovolemia. We tailor the use of furosemide and inotropes as required. The most common inotrope we use is noradrenaline. We have escalated from noradrenaline to vasopressin as well. And again, most of these patients, they need inotropes because they are heavily sedated, and muscle paralysis is quite common as well with using either atracurium or rocuronium. Echo has been useful in these patients as well. If you can, if there is a feasibility to okay these patients, at least you will know the fluid status of them, and you could see whether your IVC it's collapsible or not, or is it full. So demonstrating an easy way of demonstrating fluid volume. Renally, in these group of patients with COVID-19, there is a higher need for hemofiltration. Again, I think that was initially due to the overuse of furosemide initially when these patients presented. But as we've been, I would say, a bit more experienced with these patients, I have seen giving good amount of fluids, make sure patients is well hydrated. I have seen the incidence of acute kidney injury slightly leveling off. We've got patients coming in with high creatinines as an acute kidney injury without the previous history of having kidney disease. And as soon as you give them quite good amount of fluids, by next day your creatinine have come back to normal, and their acidosis would have improved quite a lot, and they've started producing normal volumes of urine. So I think, as I said, the initial way of management has caused quite a lot of surge in the incidence of acute kidney injury in these patients. Part of the disease as well, not to forget, that COVID-19 affects all organs, and I think the evidence by now has proved that it could affect your brain, it would obviously affect your lungs, it can also affect your kidneys by causing microemboli in the kidneys, and these also contribute to acute kidney injury. We've noticed also that our circuits used in hemofiltration, that they clot quite frequently. So again, good use of heparin and aiming for kind of higher APT-TR ratios have prevented that a little bit. Some hospitals fully coagulate, including our trust. We've started fully anticoagulating our patients rather than the hemofiltration circuit only to prevent this. Aggressive anticoagulant strategy required for hemofiltration, and potentially systemic as well. Surgical emphysema has been noted as well in 2 of our patients. Invasive ventilation, I can tell you, it's an absolute nightmare, and their oxygenation is very, very fluctuant. At one stage, you would think that your patient is slightly stabilized on 100% of oxygen, and then in another half an hour, you find that even with that 100% of oxygen, your partial pressure of oxygen has fallen down to 7 or 6. And your carbon dioxide has gone up to 11, 12, So it is really very, very difficult to ventilate these patients. So when you're happy that your PO2 is acceptable, then your CO2 started rising, you see a pH of 7, and then you just start, fiddling with the ventilator, and then you get somewhere acceptable, and it goes on. A good tip is, I'm not quite sure of the setup of the hospitals in Sudan now, but we've got a designated area in our theaters that we use for intubation. So though sometimes patients are quite unstable and we end up intubating them in the wards, or intubating in A&E as well. But intubating in the wards is quite difficult. You have to have an ODA with you. There is always a second anaesthetist there. And plus the fact that you have to wear full PPE. So we would rather we have designated this area just to get things, ready, and aim to bring the patients down to the theater, intubate in full PPE, and then put the lines in, as in, definitely you'll need a central line, you will need an arterial line, and you will need an esogastric tube as well. So in one setting, we do all these things rather than just intubating, taking the patient to intensive care, and then again the intensive care team has to put all the lines as well. So we do it in one sitting, intubate, central line in, arterial access, and an esogastric tube for feeding, which is quite important because these patients will remain a while ventilated. We've also got a pro forma of drugs. Again, I think this is all down to to our colleagues in Sudan, as in to formulate these things. Get a pro forma of drugs so that it's universal, so that everybody knows what to use. Because at the time of crisis, you want something quite universal and cardiovascularly stable. You don't want to get into the habit of everyone using what they think is right. Plus, when you use a standard thing, you remember the doses quite quickly. So in your head, you will know, I'm using this, I'm using that, and this is the dose, this is the amount I need to use. Because when you see these patients, they do deteriorate quite quickly, and when they call you, it's always an emergency. Keep an intubation tray ready to use with a laryngoscope and a bougie. Whatever laryngoscopes. We've got IMAX, but at the end of the day, most of us have reverted to using the normal laryngoscopes that we use with the Macintosh blade. So whatever you are experienced with, it's better to use. It's good to have a bag, as in with a mask, a bag ready made with all the intubation kit ready, and with a mask, with a visor, and ready to grab it to go to any emergency you're being called to. And I all urge you, because we are all exposed to these secretions when we have bag mask and bag mask ventilation. So very carefully with bag mask ventilation, get the patient to breathe spontaneously as much as they can to pre-oxygenate them first, and then minimize bag mask ventilation as much as you can. Again, full PPE, essentially, you have to, because again, we are at high risk regarding the airway, and there is a high viral load, and everything is about the viral load. After successfully intubating the patient, always handy to have an end-tidal carbon dioxide as well, whether it's portable or whether it's in your monitors. And endotracheal tube well secured. You don't want to get into a position when the endotracheal tube slips out and then you have to redo this again. As I explained earlier, arterial access, central access, and an NG. Sedation, whatever sedation you guys use, we use fentanyl and propofol standard. We've been using it for everyone. And muscle paralysis, achacurium, rocuronium, whatever it's available over there. Because again, you don't want to get these patients light sedated and then they cough, the tube comes out, and that's a disaster recipe. So we don't want accidental extubation, putting yourself and everybody else at risk. Again, this is an observation of the kind of disease, phases of the disease. So we've got a mild phase, which is like day 1 or day 0 to probably day 4 or 5. And then comes severe disease, or another phase, which is you get another dip in kind of day 10-ish. And then after day 10, 2-3 days, you either become better or you get worse, and you fall into the category of critical disease, where things can get really bad and multi-organ failure can happen. So mild disease, it's non-pneumonic and mild pneumonia. So you get kind of viral. If you get a pneumonia, it's a viral pneumonia, and that is in 81% of the cases. But most of those 81%, they don't get kind of a pneumonia. You get these phase where you get a high temperature, the fever, the myalgia, the headaches, all these kind of non-specific symptoms. If it progresses and becomes severe disease, then you get kind of dyspnea, you get your respiratory rate becomes a bit higher, your saturations kind of drop, and you develop lung infiltrates. And these are patients who come into hospital with difficulty in breathing, and they've done their CTs or chest X-rays, and they show lung infiltrates, and this can be as early as the first 24 hours to 48 hours. And this manifests itself in 50% of the cases, comes in with these infiltrates. And people who fall into category of the severe disease, these are 14%. If you progress and get critical disease and respiratory failure, and then you get septic shock and or multi-organ failure, and this has been observed in 5% of the cases. These were observations from China. Again, there is this cytokine release syndrome, and evidence now have suggested that a group of patients with severe COVID-19 might have a cytokine storm syndrome and a secondary hemophagocytic lymphocytosis as well, which is HLH, which is underdiagnosed. It's a hyperinflammatory syndrome, and it's characterized by fulminant and fatal hypercytokemia with multi-organ failure. HLH is most commonly triggered in adults by viral infections, and kind of it accounts for 3.7 to 4.3% of all the cases generally in sepsis. Features of HLH is persistent fever, high ferritin, pulmonary involvement, ARDS for 50% of the cases. And the cytokine profile resembling HLH is associated with COVID-19 severity. Blood shows high interleukin-2, interleukin-7, and gamma interferons, and many other inflammatory cytokines. Moving to a bit of pathophysiology, the main thing is the hypoxemia, and based on that hypoxemia, there are 2 phenotypes that have been identified: phenotype L and phenotype H. Phenotype L, where there is dysregulation of the pulmonary perfusion due to pulmonary microthrombosis, and this is COVID pneumonitis. The phenotype H, it's the ARDS-like type, and it has got patients develop or show signs of pulmonary edema and ARDS-like. But the type of phenotype L, it is not ARDS secondary to pulmonary edema. These patients get hypoxic because of PE or microemboli in the lungs. That's why initially most of these patients, they did really bad because we got it wrong initially in case that we thought it's ARDS. So we started using high PEEPs on CPAP, high PEEPs on ventilator with positive and expiratory pressures. And we were treating them like ARDS with pulmonary edema. But with the Chinese experience and experience here in the UK, and post-mortems done showed that these patients do have microemboli in their lungs. Dysregulation of the pulmonary perfusion. If you look at the lungs, they've got low elasticity and low VQ mismatches, low recruitability, and limited peak response. With the recruitability, I mean, if that when you want to recruit a lung, what do? You increase the peak expiratory pressures. So these are what we call PEEP, and that's why these patients did not respond well when you used high PEEP, because again the pathology is different. The pathology is not pulmonary edema. The pathology is microemboli in their lungs. The other type, which is pulmonary edema collapse, which is ARDS-like, the elasticity of the lung is high and the lungs are non-compliant because of this high elasticity, and they recruit better because these alveoli are filled with pulmonary edema fluid. So when you recruit them or when you distend them with PEEP, this improves the oxygenation. And with this ARDS-like picture, there is a high right to left shunt as well, which again does respond to PEEP. The disease course, we do have a hyperacute form of the disease where there is severe hypoxemia and breathlessness leading to immediate intubation. So you find the patient coming in with this hyperacute phase, they are severely dyspneic, they are peri-arrest, and they need intubation imminently. Some patients come in when they are kind of improving, they've got moderate or severe hypoxemia, but they are only show signs of respiratory distress on kind of mild exertion or some exertion, and their work of breathing is only kind of moderate, so you can watch them, these patients. You've got others who fall into the category of being in the middle, so that they're kind of biphasic. So there is initial improvement, again, which is, this is typically they improve in the initial phase of the disease during the first 5 days of the disease, and then typically 5 to 7 days later, that's followed by an acute deterioration with hyperinflammation, worsening respiratory failure, and bilateral infiltrates and consolidation. So if you look at the kind of previous things that I've explained, if you put all this picture, then you get like a phase of the disease which is 0 to 5, and then 7 to kind of 10, and then after that 12 onwards, where patient kind of deteriorate with respiratory failure and multi-organ failure. Again, these are all, this is information from, as I said, different hospitals, but I tried to get something which is kind of universal. So this is management of respiratory failure, COVID-19 intubation. If you've got the targets of minute ventilation, 90 to 94% of oxygen, PaO2 of more than 8, that's your targets after kind of intubation, CO2 of less than 6, or a normal pH rather than, and plateau pressures of less than 28. then tidal volumes out. We usually use like 6 to 8 mils per kg. We usually ventilate our patients according to the ARDS-NET criteria, which is ideal body weight. So you don't ventilate the 6 mils per kg according to the normal body weight. So you calculate the ideal body weight from the height of the patient, and then you ventilate 6 mils per kg according to the ideal body weight. And that's, if you go back and read about the ARDS-NET criteria for ventilation, that will be quite kind of, you could go back and read on the ARDS-NET. Again, phenotypes identification is very important. Again, the modes that to use in ventilation, there are kind of APRV and which is release pressure ventilation. But again, we found that with APRV, the incidence of developing surgical emphysema and pneumothorax is slightly higher than normal. So nowadays we use synchronized intermittent mandatory ventilation more. So you set your tidal volumes according to your, as I said, ideal body weights. But again, any mode of ventilation, because ventilators are different, any mode of ventilation that you feel appropriate and is used in Sudan, as long as it's not harmful, then that's. Always remember, don't use high PEEPs. Positive expiratory pressures, not high, because again, you don't want to trigger a pneumothorax or worsen the cardiovascular stability of the patient as well. In summary, the early recognition of hyperacute disease, need for immediate intubation, high risk of cardiovascular events. So it's very important to try to see where your patient falls, which category does your patient fall in. Because again, intubation is a high risk procedure, and a patient can have massive cardiovascular collapse due to the medication that we use, and most of these patients come in peri-arrest. We had 2 cardiac arrests just kind of after intubation or peri-arrest states. So again, we try to use drugs that are as cardiovascularly stable as possible. Short and adequate use of CPAP, which is continuous positive airway pressure ventilation for hemodynamically stable patient with moderate hypoxemia, low respiratory drive, and low inflammatory phenotype. Beware of the biphasic, those patients that fall in the biphasic category, because again, they can go off quite quickly. So if you've got a patient that has been admitted initially and you think they are in the acute phase of the disease, or in the kind of stable stage of the disease, and they are doing quite well first 5-7 days, and then suddenly they crash, be aware that some of these patients will show these despite they are stable, but they could easily go from a stable to an unstable condition. Early differentiation of the L phenotype, which is the preserved compliance and dysregulated pulmonary perfusion secondary to thrombi, to PEs. Don't use high PEEP, it's not ARDS. Regarding ventilation, it is a very risky business. We'll try to avoid it as much as we can, but if we can't, then we have to find a way of dealing with it, and find a way to make it as safe as possible and less harmful to our patient as much as we can. Early high PEEPs may be quite harmful. It's not ARDS, as I've stressed, and I can keep stressing, in the early phase of the illness. We avoid spontaneous ventilation early in ICU. It may be harmful. So When we are happy, that's why most of our patients are paralyzed, because you don't want them spontaneously ventilating while they are intubated in the early phase of their disease. There is clear microvascular thrombosis happening in the pulmonary circulation, leading to increased dead space. Some evidence from Italy of early pulmonary fibrosis, possibly oxygen related, possibly inflammation related. This is all just post-mortem kind of observations. Wedge infarcts in lungs on images and pulmonary thrombosis with or without DVT has been noted as well. Reintubation seemed to be quite common because of airway swelling, and patients were noted to have stridor as well. So usually we accept PaO2s of 8, pH 7.35, even if the PCO2 is not to our liking. We kind of accept a normal pH. As long as the pH is normal, it doesn't really matter how much that CO2 is. Preferred mode is synchronized intermittent mandatory ventilation with an ideal body weight 6 to 8 mils per kg according to ARDSNet. Calculate the ideal body weight from the height. Remember your PF ratios. PF ratio is the ratio of the arterial oxygen to the inspired oxygen. Okay, those who are not familiar with PF ratios, please go and read about the PF ratios, because it is quite important, because you can categorize where into the ARDS your patient falls. Is it mild, severe, or moderate ARDS? Okay, so please go and revise about ARDS and PF ratios. Most of the time we need to use high respiratory rates on the ventilator. So if you dial the resp on the ventilator to 20 or 22 with an IE ratio of 1:1, because again you will find that your patient will have a high CO2, so you just ventilate them to a normal pH. So you wash the CO2 to a normal pH. Yeah, PEEP of 10 might be needed in the early phase, and then at most of the time, if these patients spend more than 10 days in ICU, you'll find that they are showing signs of the typical ARDS, which is sepsis related. And in this case, you might find using a higher PEEP, which is the positive end expiratory pressure, to keep your alveoli open for better oxygenation. You might need to use that, because again they fall into that category. Now they might be developing a ventilator associated pneumonia or bacterial infection on top of their initial pathology, and then things become more and more complicated. In the early phase of the disease, the lung compliance is very good, and we've seen our patients on their ventilators. The lung compliance initially is around about 40 or more, so the lung compliance is really good. And as the disease progresses, the compliance of the lung deteriorates, indicating a superimposed bacterial infection. And these patients, when we ventilate them, say initially they're coming from home, they've been insulating for 7 days, and they spend a few days in the ward. So by definition, they are in their day 13 or 14 of the disease, and then they suddenly need intubation because they now are deteriorating, getting into the severe criteria of the disease. You will find that their lung compliance is below 20. Patients are most of these patients, as I said, heavily sedated, muscle paralysis, and this is used to control the, we need that so that we can control and take over the ventilation appropriately. Our intensive care is an 9-bedded intensive care, and during the course of the disease, initially, we were way beyond our capacity, and we were extending the theaters and ventilated patients. So we had double the normal amount of patients that we had initially. And then we started transferring out, obviously, to other hospitals. So you can imagine if if the UK hospitals are overwhelmed, I'm sure the situation in Sudan will be you know will be a very difficult situation, put it that way. So I think it's better that we get prepared. I hope things don't go that far and the disease get controlled, but we have to be prepared that we will extend way and beyond our capacity in intensive cares, and we probably need to ventilate those patients in theaters using our anesthetic machines, which is obviously not ideal because we had difficulties ventilating them with the anesthetic machines because anesthetic machines are not made for long-term ventilation. You need to change the filters every 24 hours, and that will again put patients at risk, staff at risk, and everyone at risk as well. And they need to calibrate, change the filters, do all these things, plus the soda lime as well, that needs to be changed quite often. And you will notice that the patient, the CO2, despite what it goes up and up because of obviously because of the soda lime that you need changing. Again, there is always the risk of running out of oxygen. I think, I don't know nationally in Sudan whether people have looked into every hospital has to look into their supply of oxygen and to see whether they can cater, because if you look at non-invasive ventilation uses quite a lot of oxygen. Even these patients, when they come in, they are awake, at least they will need 15 liters of oxygen on an on-rebreather. So the oxygen supply is quite important. Another thing is early pruning, not just once. So these patients, when they get intubated, earlier we talked about voluntary or awake pruning. These are patients that you can tell them to prune themselves and they do it. But as well, patients who are on ventilators, they need pruning. We've been pruning our patients and deproning them. So we prune patients for 16 hours at least, and then we deprone them for another 6 hours. If they are fine, then we let them. If not, then we deprone them. We prune them again. So it's a continuous thing. We've been proning and deproning patients all the time. So I think again, training and having the capacity and the manpower to prone patients is quite important. So again, the earlier you start, the better, because again, now you can train newly graduated doctors, nurses can be trained, physiotherapists can be trained, and they can help with the proning. You obviously need an airway trained patient, an airway trained person at the head end of the bed. There are so many videos you can watch online regarding proning, and I think just try every hospital to adopt a proning protocol. The Intensive Care Society UK here as well has got, if you go into their website, you can also find the lots and lots of guidelines regarding proning and how to prone patients. So I think again, we start now, it's better. If God forbid things went to the worst, then we know what to do and we've trained enough people, rather than letting things to happen at that time. And I tell you, you need at least 5 people to prone a patient, so you need to know and practice it from now on. Again, PAF ratio is coming, which is the ratio of the arterial oxygen divided by the fraction of the inspired oxygen, and it's a way that we categorize ARDS according to that. So our threshold is to prone with PAF ratios around about 13. 13 is kilopascals. We use kPAs. So it's roughly will be around about maybe 200 or less in millimeters of mercury. But again, you can adopt your own way of or protocol, saying that fine, if our patient say these are ventilated patients, they've got a PAF ratio of certain number, then this is an indication for proning. Do it even earlier, because it shows that in cases of ARDS, when these patients fall into the category of ARDS, their proning has proved quite useful. We do it early on the disease. Initially, if the patient is going to benefit, you will see that they will benefit. Benefit of proning lasts less than 4 hours when turns supine. It depends. Sometimes patients really deteriorate quite on proning. They deteriorate, they become cardiovascular unstable to the extent that we have to kind of deprone them. But try to be patient and just watch them for a couple of hours if they pick up on proning. Again, the opposite happens when they are proned for, say, example, 16 hours, and then we deprone them. You feel that as if you've lost everything that you've done, and the patient goes back to square one. So in this case, we plan to deprone them again after 6 hours, more or less. As disease progresses into the more ARDS picture, your effect of proning is much more lasting. We also use prostacyclin through the nasogastric tube, 750 milligrams TDS, and we use now, we've started using, initially we didn't use treatment dose of tinzaparil or anticoagulation, full dose of anticoagulation, whatever is used in Sudan. And again, humidified circuits with the ventilators have been, initially we used dry circuits because we were worried about, all the initial information is we don't have to use HMEs, we don't use HMEs. But now, because patients started developing very, very sticky secretion because of the dry air that goes through the circuit, and we used to struggle. We had a patient that was prone, and then he completely, his endotracheal tube blocked. I think upon proning, the secretion drew, and they were so dry that they've obstructed his endotracheal tube. So we did struggle quite a lot to kind of unblock it, and he was all right, after struggling for almost 4 hours to kind of unblock the tube. We managed, and we established kind of a good end-tidal carbon dioxide trace after that. Again, extubation is very important, and we have to plan for extubation. So most of the patients I have seen, I've heard a few of our patients, as I said, we've started kind of transferring quite a lot of patients, but within the 2 weeks mark, we've noticed that we've phoned around and asked our patients, and a few number of them have been successfully extubated within the kind of 2 weeks, 3 weeks kind of mark. I've heard that some patients have been extubated 3 days or 4 days after. So it is quite kind of, you're not sure what the course of the disease is going to be. And again, with carefully monitoring the oxygenations and PAF ratios, I think you will come to know when is the right time to extubate your patient. So the leak test is very important, because these patients, upon proning and deproning, they develop edema of their airway, and you want to know when, if there is a leak, then you know that the airway is fine, and you can extubate without having problems. Nowadays, we do wait longer than normal before extubating. If you see that the trend of the CRP is going down, that's a good indication that your patient your patient is getting better, and that will be ready for extubation. Mortality in ICU is more than 50%, if not higher. Complications and different presentations are becoming quite common. And this is a multi-organ disease. Middle cerebral artery infarcts have been noted as well in a few patients. Deep vein thrombosis as well. First case of COVID has been presented as Guillain-Barré was reported, and I heard a patient presented as Guillain-Barré. I read it a few days ago that he's been intubated, he's recovered, and he's getting better. So it is the disease is affecting a lot of organs, and it can present in very, very different ways. So we are, I mean, those of us that are anesthetists, we are the airway managers. We are always at a higher risk than everyone else. So you have to be really careful. Do not intubate patients without having a full PPE or personal protective equipment on. Treat every patient as COVID until proved otherwise. Follow the resuscitation guidelines in Sudan. Our UK guidelines in resuscitation have been changed completely, as in, you know, what to do if you have got a cardiac arrest. I'm not going to get into that, but I think it's worthwhile revising your resuscitation guidelines. Donning when you put in your personal equipment, protective equipment, and doffing is when you take them off. We have buddies, we call buddies, or people that help you to, they are well trained, they know how to, what is the appropriate way of putting the gear on, because usually when you are going in an emergency, it's, you know, your mind is there with the patient, and it's very difficult to note whether you've missed something, whether you've even missed your mask or missed your hat or missed any, or the visor or whatever you wear, you've missed it. Then there is always someone there that will tell you, oh no, you need to, you know, you need to do this properly. Be safe, please, and make sure others are. Please look after each other. Look after your colleagues. Make sure that they are wearing the right things. If you see something not right, please let them know. Maybe they don't know. Just let them, you know, in a nice way, just tell them, you know, this is not right, this is what you should do, this is what you shouldn't do. So please, let's look after each other and after ourselves. I'll share with you now some X-rays. These are patients in our trust, and these are patients that I've personally dealt with. So these are patients coming in with this picture. This is a patient coming in day one, or day one in hospital, but probably day 7 into their disease. Most of them, they come in after they've been isolating for 5 to 7 days at home. So you can see the bilateral infiltrates here. So this patient is not intubated. Same patient got, this is a chest X-ray post-intubation of the same patient as well. This is another patient coming in again. You can clearly see the bilateral infiltrates. Horrific X-rays, really. Same patient a few days later. So this is first one on the 4th. This is an X-ray on the 6th, and this is the same patient on the 12th post intubation. Another X-ray again. Bilateral infiltrates. So you could see if you look at these X-rays, it's mostly lower respiratory mostly. But again, as it fluorides, it becomes affecting both lungs. Again, this is post-intubation. If you see this patient here, she's got. This is a patient that I have seen. Just a second, I might be confused a little bit. No, okay. I'll go through the CTs first, and then I'll show you a patient that has developed. She's an asthmatic, a lady in her 60s, asthmatic, and she developed a pneumothorax, secondary to secondary to ventilation, essentially. So again, this is a CT scan of a patient, again early in their disease, as in day 4 or 5 in their disease, I remember. So you could see the ground glass appearance on their CTs. And I think early in the disease, the Chinese did a lot of CT scans, and actually they diagnosed patients based on their CT scans because you don't want to listen to the chest. I think there is no need to listen to the chest, essentially, because if you can do a CT scan, it will demonstrate this. And plus, you'll be putting yourself at risk and listening to the chest, and it's not going to demonstrate much. But the CT scans are diagnostic. So this is the patient that I've been showing you here, and that's her. So that is when she came in. She's a lady in her 60s, non-asthmatic, otherwise she's fit and well. So that's the initial X-ray when she came in on the 4th of this month. And then 10 days later, because she spent like 10 days in the ward after coming in. So on the 16th, and she was on CPAP for almost 10 days. This is her X-ray on CPAP. And that is her X-ray post-intubation. So if you notice, there is a chest drain here. Okay, so this patient developed a pneumothorax and put in a chest drain just an hour into kind of intubation and ventilation. So I presume it's mostly due to asthmatics being quite difficult to ventilate as well. You see the central line is on the right side, so that pneumothorax is not related to the central line. This is another patient who have been a success story. This is the first patient that we've seen actually in our ICU. He's a 45-year-old Moroccan gentleman. He's fit and well otherwise, and he came in with this chest X-ray on the day of admission, so you could clearly see the bilateral infiltrates. And then almost I would say 5 or 6 days later, you could see he's developed surgical emphysema, and he was extremely unwell. He was on inotropes, obviously ventilated on inotropes, and he was proned. And he's the one that I've told you earlier. We had a patient that was proned, and then his tube completely blocked. And at that time, our management was to use high doses of furosemide, plus we did not use humidified circuits. So our circuits were really dry, and obviously patient did not receive any kind of nebulizers because of the aerosolic nature of using nebulizers. So I remember we've deproned him. We managed to suck out we even used sodium bicarbonate to dissolve these secretions, and we managed to unblock his endotracheal tube. And the next day he was on 100% of oxygen, and he was transferred for ECMO. And these again, this is one of his latest X-rays before being transferred for ECMO. And I spoke to his nephew, and 2 or 3 days back, actually, he called us to say that this patient has been decannulated from the ECMO, which is the extracorporeal oxygenation. He's been decannulated from that. He's had a tracheostomy, and the tracheostomy was also removed. And when he woke up, he was asking, it was myself and 2 other colleagues of mine from Iraq, and he was asking, where are these 3 Arabic-speaking doctors that I've spoken to? Then his nephew explained to him that, you know, he's been there in another hospital. He promised to come and visit us, and I think that that's a success story to tell. And you know, despite that we almost lost him that night. So back to pruning. There is a checklist I've kind of printed from our trust, and I'll put it up here. As I said, I mean, I'm not trying to impose what we do, but as I said, it's just to enlighten you guys so that you can do your own performance well, or add or subtract according to whatever is available to you in Sudan. So there are, the checklist is quite important because so that everybody knows what their role and what to look for as well. And again, it's kind of it's a learning process for all of us, isn't it? So safety and productivity is the goal. Check out also the ICS, which is the it's the Intensive Care Society here in the UK. I think I'm getting a bit thirsty here. No, and it's not pruning, it's pruning guidelines. The ICS pruning guidelines. And deproning also is as important as pruning, so there are a few more mistakes here. There are many videos to watch in the, I mean, if you go to YouTube, there are so many videos to show you how to prune. So I think adopt one that is feasible in the hospital, and one that you think they can train as many health workers as you can. This is the checklist that we use in our trust. Feel free to print it out. It's from the Intensive Care Society. So if you go into the website, you will find this, or you might find something similar to that. These are the kind of pruning positions. So if you see, pruning is, I mean, it's not easy. Patient is on 3-4 pumps, you've got the ventilator, you're worried that you can, you know, easily lose your airway. So you have to be quite careful, and it needs a lot of training. But again, if you keep it simple and to the facilities that you've got, and you train as many people as you can, it becomes an easy thing to do. Again, this is a patient. This is not a patient in our hospital. This is a picture from, I got it from YouTube, essentially, from the internet. So it's, you know, it's there for everyone. So it's not breaching any patient confidentiality. This is awake voluntary pruning. As I said, we can do it at home with oxygen, high flow oxygen, or CPAP. It has shown good and positive results. This is again something just to show you guys, you can adopt that as well, as in, you know, this is a checklist for intubation. Again, what we need, plan A, plan B, and plan C if intubation is failed. So again, you can feel free to print that out, or you can formulate your own. Again, the intubation grab bags, where you got a designated bag, you put different sizes of ET tubes and laryngoscopes and everything as well. Emergency drugs intubation, as I said, we use, these are the drugs that we use. We use fentanyl, ketamine, and rocuronium, and obviously you have to have some uppers as well, metronidone and the rest of it, and your normal adrenaline and atropine and glycopyrrolate. Again, this is the plan if you did not manage to intubate, and we hope that we don't get into a plan D with failed intubation. This is a general plea. Please look after yourselves, look after others. There have been quite a lot of death in our healthcare profession. Not only doctors, nurses, porters, ambulance crew. So please, please, please look after each other and look after the people and your colleagues. Alert them. please, if they are not using the right PPEs or if they are entering a high risk area, at home or everywhere, even in your own area that you live in, or your elderly are quite precious, please keep away from them in these difficult times and try to minimize contact as much as you can. You shouldn't be meeting friends, and no gatherings as well. And even within your colleagues at work, try to keep your social distance away from others, because you don't know who's got it. And as you are all aware now, that during this period when you don't show any symptoms, you could be a carrier, and you infect 3-4 people in doing that. Be an advocate to your family and your friends. Take care of the environment as well. Start with your hospitals, where how do we put our PPEs, how we don and we doff them, in plastic bags in an appropriate place. Make others feel a bit more comfortable while you're doing this as well, and teach them. All contaminated equipment should be disposed of appropriately. Workers who are handling these equipment, personal protective equipment, should also be wearing full PPEs as well. Environmental activists, I call you. I think this is the chance to be heard, and this is the chance that we, look after our environment and our hospital everywhere around us, where we live as well. Planet Earth is not ours. Don't treat it as if it is. It is a gift given to us. So let's respect it and let's take care of it. I think COVID-19, we can say some positive attitudes as well towards that. Majority of people are getting better. Please isolate if you've got symptoms, please. That's one thing. This is the air feels clearer, to be honest. When I'm going to work, there's no traffic. There's more fresh air, less pollution. Keep your social distance from others. This makes us, teach us how to respect privacy of others as well, and keep our distance. Caring about each other and appreciating each other more. Away from social media. Social media, the negative impact of social media. There are so many things out there in the social media which are quite negative, really. And a lot of false information in the social media. So it's a nice tool, social media. Let's keep away from the negatives of social media. More exercises. We can exercise at home now. I mean, there is a lot of time, especially during this time where people are locking down and staying at home. You can use this time to, exercise, talk to each other at home. Family coming together, helping each other in chores, and more time to think about ourselves, think about the future, and think about what you want to do tomorrow, and what you want to do in your future, and so it really gives us an insight into so many things. You might even get your car washed. I had my car washed. Thanks to my neighbors. I was going to a night shift and I was surprised. They gave me a lovely surprise by washing my car. This is where I live. It's lovely, nice, no crowding, fresh air. So let's take care of our environment, and that's me at work. Acknowledgements. As I said, all this information, I gathered it from different kind of sources. So studies made in Italy. Father of ventilation, Professor Gattanoni. I think if you read his reviews in ARVS and ventilation, it's fantastic. It's also collected. I also collected the information from webinars, ICU consultant based in the UK and else, Intensive Care Society webinars. Trusted websites, and my humble personal observations and observations by other people in our trust. And this information, I can say, is valid at this time, but it could change. you know, I might be wrong in some things and stand to be corrected in others as new evidence emerges. And the changes might occur as we know more about this viral syndrome or SARS-CoV-2. Check out also the JAMA guidelines for COVID, which is the Journal of American Medical Association in March 2020. And I hope that this has been useful, and thank you very, very much. Okay, and I hope we don't need to go into all of this in Sudan, and I hope people get better quite soon and don't get overwhelmed as we are or will be. Thank you very much.